Nei, gefa hann gott klapp, þetta var lélegt.
Okay, folks, good morning again, welcome back. Anybody who's interested other than me, the current score is New Zealand 16, Ireland 0. No. Nil's never good. Okay, so I'm going to walk you through some old research that we've done, and maybe this is an example of where academic education for ambulance personnel can take a system. This is an example whereby we have taken a problem that we knew we had. We've done the research to identify it. We've done the research to look at a solution. We've presented that solution nationally, and as a result, national protocols have been changed to match it. So we're going to look at the horrible, 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 horrible stigma we have about spinal immobilization. Naturally, it's evidence-based medicine, and we will be taking clinical expertise, external evidence, and the patient values and expectations into account as we go through this little presentation. Here's a picture of the 1920 Ambulance Governing Council of Ireland. And as you can tell, they are wondering how many spoonfuls of sugar is required for a cup of hot sweet tea, the perfect treatment for shock. I joke, but essentially this is what's been going on where I live. Okay? And how many of those people wearing those hats do you think are paramedics? The people who control the paramedic program? None of them. So we might have educators, maybe a physio, maybe a pharmacist, a few nurses, a few docs, but we don't have any bloody paramedics. So the people who decide what paramedics do and need to do aren't actually on the authoring boards. That's a problem. How do we change it? Can we change it? Should we change it? No, because if we leave it as it is, it's all nice and warm and cozy and fuzzy and nobody gets upset. So I want to give you the perfect example of why we cannot use hospital process. This is Professor Archie Brain, who in 1989 invented the laryngeal mask airway. Yes? And since then, he's been a very rich man, and laryngeal mask airways have been used thousands and millions of times throughout the world in operating theatre, and have been absolutely fabulous and a revelation, and you can keep them much lighter in terms of the anaesthetic, and the recovery is much shorter, and there's less trauma on the airway. So let's put them on ambulances. They're rubbish. They're absolutely rubbish. Because how does a patient come into operating theatre? They are sedated, they are elective, they are fasted, they are paralysed at the same height, in the same light level, and the laryngeal mask airway doesn't need to be secured because they ain't going anywhere. But Archie said, let's put them on ambulances, and because he was a consultant, everybody went, yep, that'll be perfect. Here are the instructions as to how to insert a laryngeal mask airway. You hold it like a pen behind the cuff and you push it until you get resistance in the funnel shape of the trachea, da-da-da-da-da. Except our patients are not sedated and paralyzed. And if you wiggle around in the throat and you stimulate vagal tone, you are going to lose a finger. And you then have to come down the stairs and it will fall out. And you will then put an ambu bag on the end of it, and it will pull it out. But because it works in the hospital, we'll put it on an ambulance. So we set about proving them wrong. And when we looked at it, the laryngeal mask airway was in fact the least popular of choice amongst all paramedics, had the least regurgitation prevention pressures, had the least stability, was the most expensive, so we got it removed. Not through fighting, not through swearing, not through kicking, but through presenting an evidence base, through running an actual process, through running a clinical trial, and presenting it then to our directorates, who said, actually, you have a point, and let's stop using them. So they've been removed. So it is an evidence-based approach, and it is the way we feel we should progress. Here then is our protocol for spinal mobilization for an adult, and it basically follows one of those horrible American checklists out of one of those books. It says if you have a fall greater than this, or the speed is bigger than that, or you get gunshot wound, you will nail them to a spinal board. Yes? It doesn't matter. Think about this logically. If that's what we're being taught to do. Now, I'm a simple man. A spinal board is flat. A patient is S-shaped. So nailing an S-shaped patient to a flat spinal board can never really be very good, can it? But because they do it in the hospital, and because that's what we've always done, let's just keep it the same. So we developed a research workshop, and we decided to look at all the traumatic events, and we decided to look at all the trauma protocols, and what are we actually doing? Because most of them were transferred either from the Vietnam War, or from hospital, or because some doctor who had big political power liked it. So, here's an interesting diagram. Are you all familiar with this picture? I heard somebody mention it over there when I was sitting down earlier on. This is taught in all of the trauma manuals, regardless of which colour you choose or pick or edition or whatever. This is known as Waddell's Pediatric Injury Prediction Triangle. Yes? Where Waddell says, if you have a kid because they're small, they get hit by a car, you get a collision in the lower limbs, they're flipped onto the dash, they get a chest injury, and then they're catapulted down the road and they get a head injury. Yeah? All had that in your training? Not education, of course, your training. And let me move on. So, the research group set about, how do we deal with all these spinal patients? Let's look at the evidence that Waddell used to come up with this theory that's accepted globally around the world for trauma management. We couldn't find it. I actually had to get the librarian to dig through all the various archives to find the paper, because when it was done in 1971. Okay? Now, can I suggest a lot of things have changed in the motor vehicle industry in 50 years? Kids are still the same, but a lot of things have changed. How many patients do you think were enrolled in Waddell's study that changed the way we deal with pediatric trauma injuries globally? How many patients do you think were in this study? Well, it was better than that, it was 10. Okay. What was the age of the youngest patient in Waddell's pediatric injury pattern prediction model? 21. But he was a very eminent doctor, an eminent physician, we've got to believe. It's madness. It's absolute madness. And we weren't the first people to recognize it. Here's a study done by Haley et al., and they said pediatric pedestrian versus motorcycle injury. They looked at 4,500 patients 30 years ago, and found that although the concept is sound, there is no evidence whatsoever to support it. None. So why the hell, 50 years later, do we still teach it? I can tell you one place where it isn't taught. There you go. So this led us to believe, my God, what are we actually doing in all of this traumatic injury? Where does it come from? Who says we nailed somebody to a spinal board? Why? It's the wrong shape. It's not patient-shaped. And if you're on a spinal board for 3 hours, like we heard about the transfer times, it's huge. So we looked. Hausfeld is the master in this. Look at the dates, 98. So 30 years ago, or 20 years ago even, Hausfeld, etc., looked at 2 studies. And there's 2 mad studies. Get these 2 papers. It's comical. A 5-year study of 454 patients. One in San Diego, where it had full ALS attendance, as you and I would know it, and all bells and whistles and ambulances and fire trucks and all the rest of it. And one in Malaysia, where they used what we call a vanbulance. So that means a van turns up and you open the back door and you go, whoosh. Okay? And guess what? In terms of neurological disability, the patients were better off if they were thrown in the back of a van than if they had full and total spinal immobilization carried out. Now again, I'm a simple man, but something's not right if you throw somebody in the boot versus you nail them to a spinal board and go through all the process we do. So we thought, this is madness, let's look further. We then looked at ischemic pressures. It's madness. Again, 25 years ago, if you use a spinal board, particularly with protracted journey times, like anything over 30 minutes, 30 minutes is classed as the time where we get necrotic skin breakdown on a spinal board, and yet we're happy to have them on for 2 and 3 hours. That doesn't count for how long they may also stay on the board in ED. So not only are we not doing them any good, we're also doing them quite severe damage. But because it's what we've always done, hey, let's keep on doing it. They hypothesized that alert, stable, and cooperative patients do not require mandatory immobilization of the C-spine, even if a clinical decision rule is positive and radiography is indicated. Okay? So even if there's a break or a confirmed fracture of some description, the self-splinting and the manual immobilization of those patients that are hemodynamic enough to do so will stop the movement themselves. And what do? Oh, let's just manipulate your head to start with, and we'll work from there. Okay. 25 years ago, the patient comfort is better. So we then looked at movement. So if our intention in nailing somebody to a spinal board is to stop movement, how effective is it? So this is an interesting study. Again, look at the age. It's 15 years ago by Luscombe, and they used an operating table, immobilized the patient on a spinal board, and then did a head down, a head up, and lateral left and right tilts. Yeah? And they did that on both the spinal board and the vacuum mattress. Now, without going through all the figures, if you look here, just at the head up figures, the movement on a vacuum mattress was 3.3 degrees from the midline, whereas on a spinal board it was 19 degrees. So we know then a vacuum mattress is 6 times more effective in terms of immobilization than a spinal board. But let's nail it to a spinal board, because we've always done it. The actual recommendations that came out, the backboard should not be the preferred surface for transfer of patients. But what did we do? Put them on a backboard. That's what we've always done. Hard collars then also increase intracranial pressure. So we've got skin degradation, yeah, we've got movement, we've got ineffectiveness based on the Malaysian study, we've also got problems with raised intracranial pressure with the application of collars. Okay. So we thought there's something adrift here. Let's do something about it. So we set about our research. These are the items, the beasts that we started looking at, and we want to improve patient outcomes. This is the study we produced 6 years ago now. This actually won the best scientific presentation in the US in the National Association of EMS Physicians. So we were very delighted with it. Here's a setup. Naturally, the research followed all conditions of the Helsinki Treaty, University of Limerick, and we involved our local fire services and ambulance services in terms of the extrication. So just for clarity, I'm not suggesting there isn't a place for spinal boards. If you look at those 2 cars there, the person in the yellow car has already gone to hospital. I'm not talking about him, I'm talking about the hemodynamically stable patient who's in the blue car there, who maybe has an ankle entrapment, or he's got a sore back. They were taking a bit of time. It is hemodynamically stable. This is the area we want to protect, and we want to prevent the movement in. And when you look at these things from a biomechanical perspective, you have to calculate what's called the absolute vector. So you cannot just measure flexion and extension. You cannot just measure lateral rotation. Yeah? It has to be a 360-degree calculation of all those movements in 3 dimensions. So we use the biomechanical sports unit. So these guys are our Olympic team biomechanic specialists, and they do things like they'll examine the long jump, run up, they'll examine the golf swing, etc. So they're experts in movement. And they set up €250,000 worth of cameras, and they have the ability then to measure movement in 3 dimensions to an accuracy of 0.01 millimeters in all 3 dimensions. So we can measure the absolute movement of the cervical spine on the atlas. And here's how we do it. We put sensors on the face of the proposed patient, thereby giving us 3 planes. So you can appreciate if those 2 horizontal lines come together, that represents flexion. If they come apart, that represents extension. If they deviate in any way, that represents lateral movement as the patient's extricated. And you can see their lateral deviation measured left to right, rotation measured on the peg. And we set about then going through all the standardized extrication procedures using a 6-man extrication crew, so 4 fire, 2 ambulance, because that would normally be a deployment for a single vehicle RTA. So we said, first patient, nothing, just get out. Then we said, patient with a KED and a board, patient with just a board out the driver's side, bearing in mind we drive on the correct side of the road. You're over there. Obviously then a KED with or without spinal board on the opposite side, and again out the rear window. My colleagues then did some hideous mathematics, of which I have no idea, and we calculated then the absolute vector movements of the C-spine during those 9 extrication types. The results are frightening. Okay, so these represent degrees of actual vector movement in 360-degree vision. So you can see quite clearly then, the worst by far is the application of a KED. And what's a KED designed for again? Oh, it's designed to get people out of sitting positions in cars. Okay, so it is by far the worst. There is 0 evidence on this planet to suggest a KED has ever been clinically trialed. There is 1 paper that suggests it might be beneficial. So we went, well, that's mad. We took that to the bosses. We now no longer have KEDs on ambulances. Okay? We looked then what produced the least movement. The least movement was the control there at 6 degrees of movement. Control means, assuming they're stable, can you get out? Yes, I can. Keep your head still and get out. Okay? And allowing them to self-splint and allowing them to self-extricate, we drop the risk of cervical spine motion by 400%. They're mad figures, mad figures. Graphically shown then, you can see on the left, here's the movement if you just allow a walk. If you look in the middle, here's the movement of a patient in a device that's commercially available for that very purpose. What I also need to show you is, this is the crew that actually did it. Now, bar the 1 man in the white shirt on your right, on your left, these were all guys from the watch. So research isn't for the fancy, research isn't for the people in the ivory tower, research is for the people who do it on the ground, because we have to drive what we need to change in our own practice. Yes, we might need some guidance. Yes, we might need some help. There's a university about a mile that way, isn't it? Go and ask them, go and help them. Here's my dog again. Unfortunately, she's still dead, but there she is. And this went a bit mad. So this was published then in the EMJ. This was subject for roundtable discussions in the US. This is somebody asking for permission to present it in Las Vegas and Nevada. And we like to think it's gone away to using some of the global spinal immobilization processes. Conclusion is that traditional extrication techniques can cause up to 4-fold increase in the absolute vector movement, and further clinical trials are required. So we now had a pilot trial, and we now went to the government and said, we're doing this wrong. We are paralyzing this country's people, potentially. So they gave us money and allowed us to do the extra trial. Here's a full-scale trial then, and these are images of patients being assessed. Open call, so we had all age demographics, all size demographics, and you can now see the addition of the two white squares, one on the forehead, one on the chest. So these are 360-degree accelerometers like you'd have in your iPhone. So we're actually testing the accuracy of the biomechanical analysis with a cross-correlation against accelerometers. And there is a correlation, so we can use accelerometers. So our next move is to go to the real world. And when we're actually doing an RTA, if the patient's hemodynamically stable and can give us consent, we're going to pop an accelerometer on the forehead and on the chest wall and actually do it under real-world conditions. The results of the trial then weren't as dramatic as the PREM trial, but still show by far that no collar is by far the best if our aim is to stop cervical spine movement. Came the question then, to board or not to board, is the question. And we've put this paper together. We went to our governing authorities nationally, and the proposal is spinal boards indicated for extrication purpose only. So you only use them to slide people out of cars, that's it. Transport should be by vac mat only, because of the ischemic issues. Mandatory application of collars removed. Yes, there is a place for them, but it's not mandatory anymore. I'm not allowed to use the word KED, so I write short extrication jacket, use, removed. Okay. Furno have a lawsuit out against me, but hey, what harm? Patient position of comfort is best. If a patient who can get out themselves can, let them. And last but not least, oh my God, please will somebody tell PHTLS to stop doing the nonsensical standing takedown. We actually had to drop that off our assessment because the results were so bad, they were so skewed, that it took us a bias off here. The actual movement is off the charts in terms of spinal safety. Our decision then is spinal rule in and not spinal rule out. What we need to do is we need to do an ethics extension. We need to follow up with ED, because now we need to do a one-year trial going through the emergency department to see of those patients we brought in who walked out, how many of them were appropriately allowed to do so. You know, how is their outcome score leaving hospital? Full-scale live trial using the accelerometers on the forehead. But most importantly, those 6 people, those 6 ambulance crew and firefighter have ownership. And what it's done for them in terms of esteem. Now, you know, now we have a fireman of 25 years who couldn't give a shit 2 months ago is now being asked to present to the emergency department. Yeah, and remember we asked earlier on, how are you seen as a peer intervention group? It's been amazing. So I have to admit, before I came to Iceland, I was trying to think of a use for spinal boards now that we've got hundreds and thousands of them in the cupboard. And I found one yesterday. Brilliant. So what I'd like to do is, we have a very short video summary of the research that I would stress again that paramedics and firefighters themselves carried out. And I think it speaks for itself. And if I can get the bloody thing to work, I'll leave you at that.
Sorry for the cheesy music. And I don't care about Falca. I'll take anybody's money.
already had its A, B, C pillars cut. They all come out, had its engine removed, its running gear removed. That means we can use it time and time again for training. You stick a GoPro camera on the dashboard, you get perfect bird's eye view of what's going on. It's actually better than my car today. Get the goes back together. See the modern fire service in Limerick. €25,000 per camera. So every camera has to be calibrated every single time, so again we can pick up movement. And then we go through the various processes of the 9 extrication routes that are commonly used. So the one we all tend to prefer is out the parcel shelf. It's actually the worst in terms of spinal injury. You can see the accelerometer is calibrating against the biomechanic markers. And we had to rotate 2 members of the crew on each time because of the back strain potential for going through so many lifts in a day, so you only ever did 2 extrications in a row. Here's the actual instructions being given by me on the left. So we actually have it pre-printed. We've actually republished this again in Emergentiav last month, I think. So lean forward, hands on the steering wheel. Right leg out. Obviously left if you drive on the wrong side of the road. Shuffle forward. Hand behind you. Rotate on your bottom. Lift your leg clear. Stand straight up. Walk to the stretcher and adopt your position of comfort. There's the giraffe, the only person that ever wears a tall collar. It's male. Marvellously handsome chap there. So obviously that's now subsequently been completed and is published and open, and anybody wants it, drop me an email and we'll send you on the papers. Hope it's been of interest. Thanks very much indeed.
Þá tökum við 5 mínútna pásu, tökum 2 fyrirlestra og svo kemur hádegismatur.